So his hand and wrist are supinated. His arm is just relaxing at his side. So I'm going to have my patient bend his elbow, and I'm going to feel in the antecubital fossa, see if I can hook. So I can hook under his biceps tendon. So to me, I feel that this tendon is intact. You can relax again. And so I'm going to start with the anterior elbow joint. I'm going to try and use the 24 linear probe, which is the highest frequency probe that we have. So if I start at the anterior elbow crease and put my probe directly down, I'm just going to widen my screen here. What I can see in front of me is the anterior elbow joint. This is radial, this is ulnar. On the radial aspect is the round capitulum. You can see this equipolar hyaline cartilage here. Over on the ulnar aspect is the trochlea. It has more of a V shape. Sometimes this is referred to as a W or a clam shape. This echogenic layer on top is the joint capsule. So if I translate medially, I see the pronator teres muscle, this big muscle here. This in front of the elbow joint is the brachialis muscle belly. And over laterally or radial is the brachioradialis muscle. Between the muscle bellies of the brachioradialis and the brachialis lives the radial nerve. So at this point at the elbow joint, it has bifurcated into the deep motor branch and the superficial branch. If I just sweep my probe a little bit distally, I come onto the radial head with the hyaline cartilage. If I sweep slightly proximally, I'll increase my depth a little bit, and I can see the fossa of the joint with the fat pads inside. So now I'm just going to turn in long axis and sweep through the joint because I always want to assess the joint first before I do anything else. So I'm on the radial aspect. This is the round contour of the capitulum, the radial fossa here, the head of the radius, which typically has a square appearance, and the neck. So this is the annular recess here. And if I sweep the probe towards the medial aspect, I come onto this pointed bony structure here, which is the coronoid process and the trochlea. The muscle belly that's crossing the joint here is the brachialis muscle. You can see the brachial artery here. And here's the tendon of the biceps brachii that's crossing the joint. So I'm going to come back to home, which is the joint. This is what I consider home. I'm just going to get a little bit more gel. Okay, I'm going to grease you up here. So I'm just going to have a look through proximally and just be sure that the proximal biceps tendon is intact. Just a quick sweep through up into the bicipital groove, into the interval, and then I can translate my probe medially and find the coracoid process here, which is the origin of the short head of the biceps. If I turn in long, I can see the short head and the coracobrachialis. I'm going to come back to the long head of the biceps, and I'm just going to sweep the probe distally now, and I'm going to watch the muscle bellies. This is the myotendinous junction of the proximal long head of the biceps. Long head muscle belly, short head muscle belly, coracobrachialis is deep. And I can sweep through these two muscle bellies. And now I see this echogenic linear structure forming, and another one. So this is the internal tendon of the biceps, the short head, and this is the internal tendon of the long head. That's the proximal aspect. And I'm going to keep sweeping the probe distally. I'll watch the condensation of the fibers here. And now I see deep that I'm approaching the elbow joint. Biceps tendon is here, brachialis is here, and here's the joint. At this level, I can see a little nerve on the radial aspect. That's the lateral cutaneous antebrachial nerve. So here's the biceps tendon. Medially, the brachial artery is here, and this is the median nerve. which I can follow distally if I choose. I'm going to come back to the biceps tendon here, and there's an echogenic structure that is crossing over the artery here, and it's just merging with the antebrachial fascia. Okay, so easily I can come back to home right at the joint, and I know that the biceps tendon is right here, superficial. If I continue to sweep the probe distally, I'm going to have to toggle the probe quite a lot to avoid anisotropy. So here's the tendon. I'm going to watch it, and as I do that, I'm going to translate my probe medially so that I can use the pronator teres as my window. So I'm going to come back up to the elbow crease. There's the biceps. What's going to happen is the long head is going to slip underneath the short head. So you can see two tendons here, two tendons here. So the long head is now slipped under the short head. And I'm going to translate the probe medially. Two tendons, short head, long head. Increase my depth. Keep my eye on these two tendons. Still two tendons. Keep going. And I'm heading towards the distal insertion on the radial tuberosity right here. Keep in mind that this is a really high frequency probe, but I can see the distal insertion right here on the radial tuberosity. So at this point, if you look at where the probe is, I've translated medially, so I've got this medial approach. I no longer have an anterior approach because I can actually see the tendons all the way to the distal aspect. And I'm going to point out that the ulna is here, and there is the brachialis tendon. So if I rotate the probe at this point, I'm on the distal biceps tendon. And I'm going to take my patient's wrist and do a little bit of a dynamic assessment. Can you bend your elbow a little bit? There, that's better. So if you have the elbow flexed about 20 degrees, you can get a much better access to the tendons in long axis. So what I'm going to do is I'm going to stay on the tendon here, try and avoid that little bit of shadowing, and I can just tilt the probe towards the ceiling, which is anterior, and then posterior to see the two heads. I can keep healing and towing the probe so that I can get a really good view. I can translate the probe more proximally and see the myotendinous junction. I know for sure that this tendon is intact because I can see it moving in continuity. I also know that I'm on the biceps tendon and not on the brachialis tendon because the radius is moving with this movement. Off here. And can you bend your elbow and just put it on your tummy here? I'm just going to change probes because of the depth. Just going to lift you up a little bit more. Okay, good. If I put my probe in the same orientation as the humerus, I should be in a pretty good position. And if I start a little bit more distal and I head towards the joint, what I can see on the screen, this is the radius here. Supinator muscle is here. This is EDC, extensor digitorum communis muscle belly. Here's the tendon of ECRB and the muscle belly of ECRB and ECRL. So I'm just going to sweep the probe proximally, and I'm going to look down here. So you have to make sure that you've increased the depth. And here you can see this fibrillar structure. Here's the long head of the biceps, distal tendons. And so what we'll do is a little bit of a dynamic maneuver, and I'll get my patient to just do a very small amount of supination and pronation. And what you want to see is that the fibers of the tendon are moving in continuity. We cannot see the distal insertion with this maneuver, but we can determine if the tendon is truly intact, because if the tendon is ruptured and the bicipital aponeurosis has not torn, it still may look like the tendon's intact. So you really need to do this maneuver. And also with tendinosis, you can usually see the bicipital radial bursa fluid in this. Okay, that's great, thank you. The last position we're going to do, lift up a little bit, the dorsal or the posterior approach. And I'm going to go back to this high frequency probe again. I'm going to move this a little bit. You need to have access to the very distal aspect of the elbow. Pronation of the hand and the wrist. Remember that the radius crosses the ulna, so don't be fooled into thinking that you're going to be on the radial side. I'm going to come down here all the way down to the most inferior aspect, and I'm going to start at the radiocapitular joint, and then I'm just going to sweep my probe towards the ceiling, so that's distal, and I come on to the radial head here with the hyaline cartilage, and then I keep sweeping distally until I come on to the radial tuberosity, which is right here. And now I'm just going to take your hand for a moment. We're just going to do a little movement here. So this is the distal biceps tendon on the radial tuberosity. So we can see that there are actually some fibers on the tuberosity. You can also assess for tendinosis at this location and compare with the contralateral, and you'll see if it's thickened. You can relax for a sec. And I'm just going to show you one last thing here. If I come back towards the radial head, I can see the insertion of the lucal or the lateral ulnar collateral ligament, which is right here. Okay, so again, if I go distally, I'm on the tuberosity here, and I come back proximally, and I can see the lucal. So this is radial, this is ulnar, the pointed end of the trochlea here, the round capitulum, the brachialis, brachioradialis on the radial aspect, radial nerves, brachial artery, and ulnar pronator teres. Proximally, so to the right of the screen is the short head, to the left is the long head. Come way far proximally, I can start to see this tendon, the short head internal tendon is just beginning, and I continue to sweep distally, and then I'm going to see another tendon forming here. So that's the long head internal tendon and the short head. I'm going to continue to sweep the probe distally. I'm going to keep my eye on this structure here. The muscle belly is disappearing, and the tendon here is right there. That little nerve, that lateral cutaneous antebrachial nerve is there. Brachial arteries here, median nerve is there. So if I look deep, here's the joint. So come back proximally. I'm going to focus my attention here. I'll just change the depth. Again, I'm using the 24 megahertz probe. So here's the biceps tendon. The superficial bicipital aponeurosis is coming across here. And you can see the fibers coming across and merging with the antebrachial fascia there. So if I was to turn my probe here in long axis, I would be at the myotendinous junction of the biceps. So it's an easy way to think about assessing the myotendinous junction. I'm going to turn back in short axis, and I'm going to focus my attention on this structure here as I continue to sweep distally. Now you can see it's changing its position, and I'm toggling my probe as I go. And at this point, if I increase the depth now, and I toggle the probe, I can start to see two tendons here, one on top of another. Here's one, here's the other. So the long head is now underneath the short head. And I'm going to continue to sweep distally. and toggle the probe again. The two tendons are here. I'll increase the depth and carry on distally. Here's a bony structure, that's the radiotuberosity. And I can move my probe medially. Pronator teres muscle belly is right here, so that's my window. And now I can see two discrete structures here on the radiotuberosity, the long head and the short head. And if I was to look more ulnar, the ulna is here. So long head is going to be more ulnar at this location. The long head is posterior. You can see that it is posterior and the short head is anterior. So at this point, what I typically will do is rotate the probe, stay on my structure. I know that this is the distal biceps because I can see the radius moving. So you want to make sure that you are not on the brachialis. Here's the long head of the biceps. And if I have my volunteer bend the elbow, let's go about 20 degrees here. And I'm just going to come with the probe down over the radius and sweep proximally. And I come right on to the biceps here. You notice there's an artery there. That's the radial artery. So if you see the radial artery, you know that you're very close. With the elbow flexed, I feel like I can see more of the biceps tendon, more towards the myotendinous junction. And again, we can do a little bit of dynamic. And I can tilt the probe and see the two heads. And I'm going to get you to bend your elbow now. I'm going to move this. So same as before, we've got the elbow flexed at 90 degrees. I'm going to put the probe in this orientation along with the same axis as the humerus. Come down on the radius and sweep proximally. So I see the supinator muscle here. Increase the depth. And here I can see the biceps tendon, the myotendinous junction there, more proximally. And so I'm just going to heel toe my probe to line it all up. We're going to focus here a little bit more proximally where we see the fibers really clearly. Can you now supinate and pronate, just small movements? That's it, back and forth. Nice. And keep going. Beautiful. So clearly we can see the fibers are moving in continuity. And again, we cannot see the most distal aspect of the biceps tendon, but we can see a really large portion of it. I can tell as I'm sweeping distally and watching the internal tendons if there's any refractile shadowing. Especially at this level, when the biceps tendon ruptures completely and the bicipital aponeurosis also is torn, the biceps tendon tends to retract and you'll see a lot of refractile shadowing as you travel down from proximal to distal. So that would be your clue that probably the biceps tendon is completely torn. You often will see a balled up tendon somewhere around this level, very far from the distal insertion. So good. And again, you want to have access to this part of the elbow, so you want to make sure that you've built the patient up onto a sponge or a towel. I see the thumb is here, but the hand is and wrist is pronated, so I know that I have to start on this side. So I'm going to come all the way down towards the table, so that's proximal. Just change the depth here. So at the radiocapitular joint, and then I'm just going to sweep distally, and I'm on the radial head now. And I keep going on to the radiotuberosity. What the other thing you can do when you're assessing here is you can look at the distance between the radiotuberosity and the ulna. Sometimes patients present with tendinosis, and it may be because the tuberosity is quite prominent. You just do a little bit of internal and external rotation, please. Thank you. Nice. All right, so this is the fibers on the tuberosity, the distal biceps tendon here. That's good, thank you. And I'm just going to sweep back now towards the table. And again, the lateral ulnar collateral ligament, the buccal, is inserting right here. Here's the radial head and back towards the radiocapitular joint. And that's it. Thank you.